Now, management continues. All patients with AMI should undergo intensive treatment for modifiable risk factors. What were they again? Aspirin, ACE, beta blockers. Secondary prevention. So you want to continue taking baby aspirin. ACE inhibitors, always a good thing. Beta blockers, all of these are then for secondary prevention. Treatment of hyperlipidemia, statins. I added another drug in there for you that is very relevant. And it's your, once again, protein convertase subtilisin connexin 9 inhibitor. And those are some of your monoclonal antibody. We have referred to that earlier, known as alirocumab or your evolocumab. Locumab is the suffix you're paying attention to, please. Diabetic control, smoking, and diet and exercise. If you're able to do this, and if you're able to educate your patient properly, where you are exercising prevention, isn't that the best medicine? Mechanical complications that we're worried about. Weakened infarcted cardiac tissue. Remember that timeline that we walked through with myocardial infarction. And at some point with that scar formation, it might become weak and may result in ventricular aneurysm and rupture. Oh my goodness, we have either septal or wall rupture. May result in papillary muscle. Might have a new type of murmur that's being introduced. A mitral valve regurg, or if you had a septal rupture, it kind of behaves like a VSD. What kind of murmurs are these, please? Close your eyes, you got this. Systolic murmurs that are being introduced newly. If it is a wall rupture, you're worried about death from what? Sudden accumulation of blood within your pericardial cavity. And say that you have tachycardia and have hypotension and you have what's known as your Kussmaul sign, meaning to say positive JVD, and you have muffled heart sounds. Worried about pericardial tamponade, aren't you? So what's your next step of management? My goodness gracious, get in there, do pericardiocentesis, and get that fluid out. Mechanical complications require emergency type of surgical issues. Papillary muscle rupture can present with acute hypotension, acute pulmonary edema. Understand that. Everything's being backed up. Here's my mitral valve. You with me? And you have regurg. Back into where? Left atrium. Back into where? Pulmonary veins. Pulmonary edema acutely. New systolic murmur. Chronically, what kind of issues are we worried about? Conduction system, big time. And if that's the case, my goodness gracious, you plant a pacemaker. Arrhythmias due to scar formation, and this is what we talked about over and over again. A major complication that you're worried about, resulting in sudden death, is the fact that you're messing up the conduction chronically. Mechanical failure, your left systole, or should I say, your left ventricle is dying, so therefore, the systolic function on the left side is also not working. And so therefore, now, I want you to pay attention to this statement. There's a lot of clinical importance for this particular stanza. Let me walk you through this. If your heart dies on the left side, and that's what you focus upon here, please. If the heart dies on the left side, it cannot pump forward. What's the active process of your heart phase? Systolic. So what kind of dysfunction would you call this if the left ventricle isn't functioning properly? A systolic dysfunction. Stop there. If I can't pump my blood forward into the aorta, where's all my blood? In the left ventricle. Wow. So it's stuck in the left ventricle. Yes. So how are you going to measure this? On the left side, a central venous pressure, or are you going to use a PCWP, a pulmonary capillary wedge pressure? You all correctly are telling me PCWP, pulmonary capillary wedge pressure. Where's my blood? In the left ventricle. Why? It's not moving forward. Are you seeing this? Close your eyes and conceptualize the only way that you get all of your questions right. So there's my blood lying in my left ventricle, increased preload, and your PCWP is increased. Correct? Yes. So now, the mitral valve wants to open, the blood wants to rush into the left ventricle. But the problem is there's blood still remaining there residually from the previous systolic dysfunction. So could that systolic dysfunction then give rise to a diastolic dysfunction? Yes, it can. Now, what does that mean to you? Pay attention here. What kind of heart sounds are you going to find here? If it's a systolic dysfunction, what does that mean? The blood is not moving forward, correct? So therefore, my left ventricle could be rather large, and it could result in what kind of heart sound? An S3. We talked about that earlier. In S3 gallop, what's happening is the fact that because of systolic dysfunction, you have a large left ventricle, and as soon as that mitral valve opens, boom, you create an S3. Stop there. But what if the blood starts accumulating in your left ventricle, right? So now it's a diastolic dysfunction because you cannot properly fill up the left ventricle, and the blood now that's rushing from your left atrium. Are you seeing this? That blood which is rushing from the left atrium through the mitral valve into the left ventricle, hitting that blood in your left ventricle is going to create a what? A fourth heart sound, right? What's a fourth heart sound mean to you? It means that it's you've heard of it as being hitting a stiff left ventricle, but with all that blood in there, it might as well be stiff. If you haven't understood that, please make sure that you go back and review what I just told you with that particular statement. Do you understand how much clinical relevance there is with each one of these statements? Some more than others, especially when it comes to pathology. Continue. Insufficient or significant damage myocardium, it cannot do what? It can't maintain the proper heart function.